My first name is really long, Shawayera, but I'm Mike Chirenje. And I'll tell you what, I qualified for medical school in 1982, and then I did residency in obstetrics and gynecology. And I'll tell you the reason why I have to go through that. The reason in the HIV, and then I subspecialized in gynecological cancer. My area of research for the past 30 years is the relationship between HPV infections and cervical cancer. So all my publications, I'm a professor of obstetrics and gynecology at University of Zimbabwe and University of California, San Francisco. And the interesting thing I want to bring to your attention, when I was a resident in Harare Hospital in 1987, when the epidemic was starting, there was no HIV test. In the Harare maternity, which is a very busy tertiary hospital, there was a cubicle, which was cubicle 13, I quite remember, where anybody suspected to have HIV was looked after in one cubicle. And if you were a resident and you entered there, the transmissions rates were like appalling. Now, just as a summary, when I lead a very large HIV research unit called a clinical trials unit funded by NIH. We have 320 people. I'm the director. I have like 15 doctors, 19 pharmacists, 19 nurses, and all these kind of people, laboratory scientists. In the 90s, if you were pregnant, the chances of your baby dying from HIV were so high, there was just basically no survival, right? If I look at a graph of what has happened over the 30 years, it's absolutely incredible for elimination of child to mother. But diagnostics have been a major part of it. When it comes to treatment, the way we formed our unit, as a gynecologist, I worked on biomedical prevention studies. The latest one was HPTN 084, where we did a clinical trial for HIV prevention. We enrolled women who are HIV negative. You give them cabotegravir injection every eight weeks, and it shows this prevention. I'm sure you're aware of that. So we've come to a situation for prevention of HIV as zero, and we are really now looking at the cure agenda. And in my research, one of the largest component of it is the cure agenda, where scientists are working, and we're using broadly neutralizing antibodies. I mean, I don't want to go into that, but I want you to give you this perception. I mean, if I had slides here and I showed you how HIV enters the female genital tract, I'm a gynecologist, and HPV, as I told you, the relationship. If you look at the vagina itself, we call it ecosystem. How does the vagina protect itself from viral infections? It's a very interesting dynamic. The first research I did with a PhD student from University of Berkeley was this research question, okay? Female genital hygiene, intravaginal practice among women, right? You actually disturb the ecosystem which protects you, because you need a pH which is acidic, and a normal woman of reproductive age produces that pH to kill the virus. Disturb it, or you have an STI, or you have something to disturb the ecosystem, HIV enters the body, right? So I've worked for 30 years in an area called microbicides. Have you heard about microbicides? Right, so I was protocol chair for a very interesting study called VOICE. If you look at the New England Journal of Medicine, I was protocol chair with, I think you know Tony Fauci very well, right? Most of you. He was the director, and Jeannie Marozo took over from Tony. She was my co-chair. And we studied all these products to prevent women until, like I just told you, the cabotegravir. So we've come a very long way. I mean, I don't want to talk much about the treatment because it's another issue where we've done very well. But I want to give the opportunity before you talk to you in terms of laboratory science, because the advances of us testing HIV and saying, you know, it started from an antibody test. We have advanced to an RNA test. And we are going, and the most interesting thing for me is for young people who are sexually active, and we want them to stay HIV negative, right? Supposing they have unsafe sexual exposure on a weekend, they're in campus, right? How do you detect an acute HIV infection and put them right on treatment, right? So there's this eclipse where we now have tests which you can detect an acute infection within a few days. And I'm going to leave it to her because it's exciting science to me. So the laboratory scientist.
So thank you so much. As somebody who has just been ambushed. Yeah, my name is Professor Nkanduluo. I'm from Zambia. At the moment, I'm a founder member of a Global One Health Institute, where we are arguing that most of the epidemics have a lot to do with environment, animals, and human beings interacting. Now, many years ago, I was working at the University Teaching Hospital. I'm a double major. I'm both a microbiologist and an immunologist. And as a young immunologist, came back to Zambia from the London School of Hygiene and Tropical Medicine, just to find this hullabaloo within our University Teaching Hospital of some disease nobody could understand. So I was challenged to say, look, this is an immunological disorder, tell us what is happening. And alas, when we put it to test and everything, it was HIV. But what I want to tell you is the journey that we have walked, not only in Zambia, but many other countries. And my major experience has been with the SADC region. When I joined the University Teaching Hospital pathology and microbiology department, what we found was that they had the diagnostic service, and within the diagnostic service, they had a therapeutic service known as the blood transfusion. And they were normally called blood banks. So I started thinking through it and said, we are busy going to institutions, to prisons and everything, collecting blood and transfusing people without testing it, because we want them to get better. Yet we are now infecting them, especially that in my PhD I specialize in sickle cell anemia. So I could see children in the sickle cell clinic being transfused, and when they were tested later, we found that they were HIV positive. So the early response as we looked at health as a whole was to separate diagnostics from therapeutic. And we started a very aggressive testing program where everybody was tested, all bloods were tested before they could be transfused. And under the health community of Southern, East and Southern Africa, I was asked to chair a whole set of experts so that we went from country to country within the SADC region to ensure that we set up blood transfusion services functional and diagnostic services functional. And this is where it all started. A lot of our people did not understand the importance of lab services. So even when they were told, can you give blood to test so that we know whether you are living with the virus or not, they were not ready. So then we started community work outside the hospitals to start promoting laboratory services and their importance. Alternative week, we were promoting transfusion services and their importance. So today, we can say safely that in a lot of our countries now, we are able to diagnose HIV and many other related infections because of this aggression within the health sector. Not only in institutions, but also in communities. And that's very important, because you can do and think a lot of good things. If the community does not appreciate, they do not participate, then you can't get there. So health system strengthening requires a partnership between the policymakers, the institutions, and the community. I did the same vein, we did the same for blood transfusion services. Now I think a lot of our countries have functional, separated blood transfusion services. When we come to testing, at that time, we were just grappling in the dark. There was arguments that only if you test through blood, then you're gonna get good results. Some said you could also test saliva. Others talked about hot spots, dry spots, so that their blood is collected on blotting paper and sent to the lab. Then they are cut, diluted, and then you test. Others argued that you could test in the urine. So you see where we're coming from. And of course, the best results were coming out of blood, but there were some results people published, and I'm one of those who published on testing on hot blood, dry spots, testing on saliva, and the difference when you tested whole blood. And then at that time we had what they called quick tests, where you got results very quickly. And there were arguments of cross-reactivity, that in fact there were people who were being tested positive when in fact it was a cross-reactivity with other infections, especially in Africa. So we started then working on how you can improve the precision. And then we've gone through a lot of different tests, some of which, as the earlier speaker talked about, you can get results very quickly, and also if you have just been exposed, you can actually be able to detect. Because before, it was said that you had to wait 1 month, and they had to put people on a post-exposure prophylaxis on drugs, and you start drinking drugs for 1 month to protect you from getting infected. So in a nutshell, there's been quite a lot of work that has been done. Those of you who are joining the HIV arena in the last few years have found things much easier than those of us who were there at the beginning, because even there were people who could have even been misdiagnosed, because the precision of our tests were not as good as they are now. And we must commend those that have been working in diagnostics, improving the different tests, those that, the laboratory scientists that have always been together to make sure that we keep testing and improving the tests and publishing and reporting on the better tests that people can use. And again, we now have the SLM, which has brought together people from diagnostics like myself. We are in the Professor Mbup room here. He's one of the kingpins of diagnostics and running a very big institute back in Dakar. So I will end here, and I can take any questions if there will be, and I'll hand over to the main speaker who was supposed to speak about the current situation. Thank you.
Thank you, dear. They were people who helped the United States government understand what could be done in country with resources. And so to some extent, we owe them a lot for their leadership and their commitment, and they're still in the conversation, as you can see. So we just want to say thank you to the two of you for helping to lead the way. And now we have one of our abstract presenters who was has written one of the best abstracts. So, it's yours.
Thank you very much. Good morning, everyone. Is it afternoon? Oh, no, it's still morning. Good morning, everyone. Yeah. So, my name is Isaac Gulemye from Uganda. I work with Anchoring Communities Uganda. It's an organization based in Uganda. And today I'll be presenting to you one of our findings from a study we conducted. Just for a bit of context, Anchoring Communities Uganda, among other partners within Uganda, are implementing a project funded by the Elton John AIDS Foundation that is aimed at increasing access to preventive or prevention commodities and products among the LGBTQ community. So this is a study that we conducted at the 1 year mark. The project is supposed to run for 2 years, and this project was conducted at the 1 year mark of implementation. Which one goes forward? Oh, yeah. So I'm sure many of you are aware that the environment in Uganda has not been very favorable for the LGBTQ community because of the recently passed Anti-Homosexuality Act, the AHA law that we all know. And as the environment keeps evolving, we as implementers also try to find out if the interests in terms of the target beneficiaries are also changing. So we thought that it's very important for us to understand the preferences of the LGBTQ community between public and private health facilities so that we can inform our programming to ensure that we're not just doing it for the sake of the proposal written, but ensuring that we reach the target beneficiaries. Oh, it takes a bit of time, sorry. Okay, so as I mentioned earlier, the study was done between November and December 2024, and our sample size was 186 sexual and gender minority persons who are, in this case, the LGBTQ community. 94 of them were identifying as female, while 92 identified as male. The recruitment procedure we used was mainly snowballing approach, where one person led us to another until we reached the target number. Data collection was majorly done on the preferences and reasons for those preferences in terms of whether they are interested in going to public health facilities or the private health facilities, as well as knowing why they have those choices. And statistical analysis was done using the SPSS version 26 to determine associations. So for the results, majority of the participants preferred private health facilities or the private clinics, and those were about 66% or 67% of the 186 participants in this study, and they preferred private health facilities over the public health facilities. And the reasons they gave, I don't know, the presentation seems to have gotten distorted, but I can mention still, the results they gave, the reasons they gave for these preferences were: one, proximity. Most of the LGBTQ community they feel the private health facilities are very close to them as compared to the public health facilities where they have to walk very long distances to get there. The next one was the perceived better care, better quality of care. And this was, I think it's because, has it moved? Okay. Yeah. So the reason here is mainly because the private health facilities are trying to retain their clients. So they will try to give as good care as possible to their clients, as opposed to public health facilities where they're trying to deal with the numbers to go out of the queue. The other one was reliability. The participants say it's very easy to walk into a private health facility any time of the day, whether it's night, late in the night, and you'll always find someone to take care of you, unlike the public health facilities, which are supposed to be open, but for some reason, sometimes they're not open. Okay. So, however, there was there was a significant, the number of essential services such as PEP in private health facilities were not always readily available. Okay, as we continue with the results, SGM persons were significantly less likely to seek services at faith-based private not-for-profit health facilities. And the reason they gave for this was a lot of judgment that is given to them because they are faith-based. So there is an issue of conflict between morality versus taking care of this. And among those who would consider going to the private health facilities, which are faith-based, the large majority still indicated that they would not disclose their SGM status, which of course affects the quality of care because a health worker will really need to understand the entire picture of a patient before they can actually give them the complete care that they need. So in our conclusion and recommendations, we see that despite the high cost of and limited availability of specific services such as PrEP, the LGBT community within the study communities were still predominantly favoring the private health facilities. So we know that private health facilities always come with a cost, but they are really willing to go there instead of going to where it's free of charge. And that raises a lot of questions when we are designing our interventions because usually a lot of the supplies and other things go to the public health facilities. The significant reluctance to utilize and disclose their status at the private health facilities that are faith-based highlights a critical barrier here because while they are very interested in going there, because of the care, still they are not going to disclose, which is still a problem. In our conclusion, one, we recommend that there is strengthening of private health facilities or private clinics because we're already seeing that the people we are targeting are very interested in going there. So we are looking at increasing supplies to those private health facilities. That will reduce the cost of access of care as we attract more people going there. Also giving in things like PrEP so that we have more PrEP being allocated to private clinics and not only the public health facilities. Then the other one is ensuring that we foster an inclusive and accepting environment for SGMs at those health facilities that are faith-based. So we may need to do a lot of capacity building. We suggest a lot of capacity building to be done for the health workers and maybe even the administrators of these faith-based health facilities to ensure that we use a rights-based approach and not only the moral or religious-based approach. Thank you very much.
Stand there maybe. I'm just going to ask reaction. Do you have any questions from the audience? Clarification, question? On this very nice abstract. Yeah. Do we have another? Or it's only one? You were first. Okay.
Thank you. My name is Godfrey Kambiwa from Malawi, and I work in the key population space. I think you raised quite important points in addition to the fact that when it comes to access of services, especially for transgender populations or self-identifying men who have sex with men, added to the fact that, you know, private facilities are a bit more inclusive, then there's also the fact of the turnaround period and the waiting period to access services because they have less people in line. So there's number one, that. Number two, it's also just the perception that they will get better care. I think there's a notion, I can only speak for my country where I come from, but there's a notion in Malawi where we believe a private health facility will give you better care than a public health facility because you are treated quote unquote almost like a VIP, you are a customer. So customer satisfaction is something that is embedded in service delivery, which is quite different with public health facilities. However, it is also not sustainable to program around private health facilities, because when the owner of the business decides, I want to close shop, you've closed shop for services. Whilst with public health facilities, we know they are going to be there as long as, government still has a Ministry of Health. So I think it's quite it's a double-edged sword in that context. And then finally, we also know, and speaking from the community itself, that most people within the community are not able to afford private health care, especially in countries where we do not have national health insurance systems and where the private health care then is paid out of pocket. So most people will not be able to pay out of pocket. And so they are still somehow stuck with going back to the public health facility. And also cases where private health facilities are not able to offer certain services, again, people are still rooted to go back to the same public health facility that they're running away from. And so I think as we're looking at programming, then the approach should be strengthening public health facilities to become more key population friendly, as opposed to totally disregarding them in favor of where the community wants to access services. At times it could be a select few that would prefer those private services because they can afford, but now I'm looking for those that are in deeper communities who might not have that option. But great presentation and great work and quite wonderful recommendations.
Thanks so much. So it's not a question, it was really just an additional, yeah.
Okay, thank you very much, and I'll still connect your question to his comment. Yes, since this was done at the halfway mark of the project, we integrated some of these findings and tried to redesign our implementation to ensure that we get closer to the target beneficiaries by factoring in some of their recommendations over the findings. Yeah, you mentioned that it's not sustainable to program around private health facilities, but still we can't display the role that they play in ensuring that communities receive these services. So what we did was to create what we call drop-in centers. It's a very common approach with programming for KPs. So we started getting commodities from the public health facilities, which are pretty distant, and then getting them to the private drug shops and pharmacies within the communities. That way, it is easier for the person to walk into the private health facility and pick their medication. So what we agreed on is a small fee that this person will just have to pay for the care that they're being given, rather than having to put in all the transportation to go to a public health facility, stay in a very long queue, and then in the end, they'll still come back with the same service. So yeah, that's one of the interventions that we are currently implementing. Yeah, thank you.
Right, we have another question here. I'm going to ask you later to talk about, there's some work which came from UK in terms of knowledge and how do you assess the quality of that person in private? How knowledgeable are they for the diagnosis of HIV, for the pre-exposure prophylaxis? I mean, how knowledgeable are they? Because the data from UK actually showed primary care, 51% really had no idea what is the latest drug to use for PrEP, 51%. So it may be private, but how good is that care? I want you to comment on that later.
Thank you so much. Kimberly Green, I work with PATH. So great that you've done this assessment, and I will say that in many places where I've worked, the preference for private sector services is very strong among key populations, particularly men who have sex with men, transgender individuals, but also other sex workers too. So one thing I wonder is if there's an opportunity to do something that's a bit more hybrid that could also benefit key population organizations, in that in some other settings, key population organizations have established their own private sector clinics, and they serve general pop, they serve key pop. The providers are often key pops themselves. And so they are making money. It's a social enterprise model, but they're making money. It's a sustainable approach. And it's blended so that they can provide services to the general population as well as key populations. So just something, I wonder if you're considering that or if it's possible. And to say there's strong examples of that in Vietnam. Clinics that are still running. They were funded through PEPFAR. They're no longer funded through PEPFAR, but they're still operational. They're sustainable because of that approach that they've taken of fee-based, not too high, affordable to their clients. And sometimes they adjust it based on people's needs. Also in Thailand, there's some really great examples. And I think other countries across the continent are doing this too. So thanks, would love to hear what you're thinking.
That's brilliant. Anybody from South Africa who knows James McIntyre? I mean, that's what you're talking about. James McIntyre formed this for the MSM groups, and and I know several people in the continent have followed his model, and that works well. You have a question there. Oh, you start with the lady. I'll come to you.
Hi, good morning, everyone. My name is Dr. Kayunga from Botswana. I work from an NGO called Developele. I just wanted to add on to what the previous speaker mentioned. We run an NGO that is supported both by external funding as well as the government. We get all our commodities from the government, all the medications and everything, and then the external funding supports the HR administration and the operations of the organization, and that has helped us create clinics that serve key populations that are NGOs, but they're not government facilities. It's an NGO that serves key populations, but because we have support of the government with commodities and everything else to support the LGBTQI population, we have been able to sustain that model within the country and serving as an option for the key populations that are not accessing services in the government space, and also they don't have funds to access services in the private space. So we have created a model that serves as an option for those key populations, which I think, riding on to what she has said, it's a perfect model that both the government and external funding funds to support these kind of these populations, which I think is another model that can be explored to be able to support the key populations. Thank you.
One thing I don't hear from the audience is disclosure. I tell you why disclosure is important. I was doing a ward round a couple of years ago, and I had a fourth-year medical student lady who called me. We take calls. We admit patients in the evening, at night, and then in the morning we do a ward round. So this young lady called me to say, "Can I see you outside the cubicle?" And the reason was she had interviewed a lady who is a lesbian, and she was shaking as a medical student. She was shaking to say she couldn't, she was shocked that this person from the township is a lesbian. You understand? I'm talking about disclosure. And I've seen this. So you are training to be as a doctor, and you're already worried that a person in your community who's saying she's lesbian is a concern to you as a provider. So I'm not hearing that coming out as, in our communities, how do you deal with those disclosures? Because you may run a good center, but they are not coming because of disclosure. To you, sir.
Thank you very much. My name is Ochonye Gulemye, and I work with Heartland Alliance in Nigeria. We identify with a lot of the findings from this work you have done, and it actually speaks about the reality, the lived experiences of key populations in Nigeria as well. I'm interested in that percentage, the smaller percentage, 30 or 30-something% that still prefers to access services at the public health facilities. Because for me, that would be the game changer. Why do they still prefer to access services in those facilities? Are there specific facilities that have certain capacities or understanding, than the other, 60-something% that are not responsive or not friendly? And so the lessons learned from this can be deployed on this other side. From our experience in the Federal Capital Territory in Abuja, for example, we trained healthcare providers, including the chief medical directors, and we found out that out of the hospitals, the 6 facilities, government facilities, that had trained healthcare workers in the area of key population sensitivity and all of that, the access for key population services shot up in a very short time compared to facilities where such trainings have not happened. And lastly, we have about 16 facilities that are hybrid, just like the last 2 previous speakers said. And those facilities actually started as specific facilities for key populations, but over time became hybrid because we want to desensitize those facilities and we want to also put a human face to the key populations. And right now, those 16 facilities are doing so well. They are generating resources for the NGO, and they are also providing services both for the communities and for the key populations. And so I think that's a model that is sustainable, and those facilities are also registered with government. They started as private, but they are now recognized, certified by the government of Nigeria to provide services that, cut across key populations and the general population. Thank you very much.
Thank you. The session was ending, but I'm told we can extend another 10 minutes if you got comments. Did you want to respond to him?
Yeah, not really to respond, but to just appreciate his suggestion about the minority, the 30% that is interested in the other. I think that's an area for us to further explore, and maybe possibly we can leverage that and see how we can change the game, as you mentioned. So that's a very good proposition. Then she mentioned something about exploring the partnering both government and private clinics, or with the LGBTQ friendly clinics. Just at the end of my slide, one of the clinics we are working with is called the most at-risk population clinics. They are they source items directly from the Ministry of Health. It's a clinic specifically for the key populations, and then we have been getting supplies from them to the outskirts, because this project is actually being implemented more of rural areas. There are so many key population friendly clinics around the cities. Very easy to access if you have the money and other things, but when it comes to the outskirts, to the rural areas, the people themselves even coming out to say they are LGBT is a very big problem there. So even just breaking the project into such communities is really very difficult. Dr. Elizabeth Kihika here from Alive Medical Services, doing very amazing work there still with the key populations, can attest to this. Like, going to the outskirts and the villages and rolling out such projects is very difficult. So it's a very delicate balance, trying to convince the district local governments that you need to allocate resources or particular things to the key populations. And one of the actual challenges we have faced is, ever since the US government cut aid, access to PrEP has been a problem for the key populations, because now most of the PrEP is now allocated for pregnant mothers. So if you're not a pregnant mother, chances are very slim that you're going to have access to PrEP, and that has been a very big setback for us. So as I mentioned, as the environment changes, we keep trying to navigate and see how best we can explore. So for us, the most at-risk population clinic has been very, very supportive when it comes to sourcing for those commodities that are very difficult to get from the public health facilities, because they are already under-stocked, the public health facilities. Thank you.
Thanks for that response. We have a comment or question here?
Yeah, comments. A lot of times, I think we usually leave out the religious component. I know you mentioned the LGBTQ persons not being wanting to go to faith-based clinics. Yes, that happens, but we need to start our conversations. I know with our experience in Nigeria where we work with faith-based, because there are some faith-based organizations that have clinics that are actually open, but with the right sensitization, with, having that conversation, that advocacy with them, starting from the fact that some of them refuse to collect condoms from us, but they are willing to provide the service. If we're able to start those, those conversations, whatever they are willing to accept, we are able to start, and then we continue to improve on that. 10 to 20 years ago, we were not able to work with the government in terms of allowing key populations, or key populations not even willing to access government services. But now, with the trainings happening, they are willing to access services at government-owned hospitals, at CBOs, and now talking about the faith-based organizations that have clinics. So let's keep the conversation going, and we start with what they are comfortable with, and then we, the numbers will keep increasing. Thank you.
Oh, thank you very much. Let's extend, the session is coming to an end. We've just been told that there are people starting the session pretty much, they have to start now. So let's thank our speaker who has done a wonderful job.